Well, good evening, everyone. I'm Paul Saraja from Minneapolis at the Minneapolis Heart Institute, and I have the distinct pleasure of welcoming you to this CVI webinar on the science behind a valve for life. My co-moderator is Dr. Ptfe Valves, and we have a great group of faculty to talk about some very key issues with regards to valve prostheses. For your information, this is a CME accredited activity with these learning objectives. And you can go to our website after the completion of this activity to get your AMA CME credit. Here are the faculty for tonight. Again, I have the pleasure of chairing this with Dr. Valves, and we also have Dr. Kapadia from Cleveland Clinic, Dr. Michael Mack from Baylor, Dr. Michael Reardon from Houston Methodist, and also Dr. Bernard Prendergast from Guy's St. Thomas. Here's the CME information for your record and use. And here's how you can also claim your credit. And just as a reminder, CVI will be digital this year, and certainly we look forward to being able to do this again in person with you all, and hope to see you all really soon. And so with that, I'd like to turn it over to my co-moderator, Dr. Valves, who will introduce our first speaker.
Thank you, Paul. And this is indeed a very important seminar issue and the subject which we discuss every day now. And the first speaker is going to be Dr. Bernard Prendergast, who is my former colleague in Guy's St. Thomas's. And he's the lead physician for the valve program in Guy's St. Thomas's. And he's going to give us his perspective on lifetime management and importance of valve choice. So Bernard, take it from.
Dear friends and colleagues, thank you for inviting me to join you in this webinar on the highly topical subject of the lifetime management of patients with severe aortic stenosis. My name is Bernard Prendergast. I'm an interventional cardiologist based in London, UK, and I've been involved in the field of TAVI since its inception in Europe in 2007. As you know, this has been a spectacular journey over the last 10 to 15 years, with a huge rise in the number of TAVI or Tavr procedures, application of a highly growing evidence base, and the application of this exciting technology in lower and lower risk patients of younger and younger age. And over this period of evolution, our emphasis has changed from one of survival and avoidance of mortality or stroke, through phases of procedural refinement and simplification, and now in the current era, a focus on longer-term durability of the implanted devices, the avoidance of complications such as thrombosis, and the achievement of optimal hemodynamics. Indeed, in most developed countries across the world, and as demonstrated in these US data published in the Journal of the American College late last year, the number of transcatheter aortic valve implantations now exceeds the total number of surgical aortic valve replacements. And this has not come about by accident. This has come about as the result of an accumulation of high-quality randomized controlled trial evidence that in turn has informed the guideline recommendations on either side of the Atlantic Ocean. So much so that in late 2020, the American College and the American Heart Association further expanded the indications for TAVI to younger patients defined as those aged 65 and older, where TAVI now stands on equal standing with a 1A recommendation compared with surgery, and is very clearly the winner in patients aged over 80 years. The same evolution of knowledge and the same accumulation of evidence now firmly underpins the use of bioprosthetic aortic valves, whether used by surgeons or interventional cardiologists, in a growing majority of patients with aortic stenosis. Whether implanted by surgeons or by interventional cardiologists, these devices have the potential to fail over time, and therefore durability becomes a central axial question in our decision-making processes. Importantly, we now recognize, based upon the randomized control trials, the average age of patients in which was 73 years, that a growing proportion of our patients with aortic stenosis are in the decades of life where durability becomes a key question regarding the choice of prosthesis. In other words, the majority of patients are going to outlive their valve based upon current durability data, whether those relate to surgical valves or transcatheter valves. And therefore, the topic of the lifetime journey of the patient with aortic stenosis and the optimal selection of the right intervention at the right phase of their life becomes a very central discussion. Thus far, reflecting the fact that the early studies of Tavr were performed in elderly high-risk patients, and that accumulation of durability is by definition a very prolonged process, our current knowledge concerning the durability of TAVI or Tavr devices currently extends out to a time limit of about 5 to 7 or even 8 years. From the pivotal randomized control trials, we have good 5-year data. From the smaller Notion trial, predominantly using self-expanding valves, we have data out to 8 years. And we have large-scale data from national and international registries, taking us to the 10-year time point or thereabouts. But it will be some time yet until we have accumulated randomized controlled trial data in considerable volume that really mandates the application of TAVI for younger and younger patients beyond the current evidence base. A further central discussion regards the concept of the function of the transcatheter valve, even in the optimal condition. Current transcatheter valve devices leave the patient with a peak aortic jet velocity of usually around 2 meters per second and an aortic valve area between 1.5 and 2 centimeters squared. In other words, we are replacing severe or critical aortic stenosis and leaving the patient with residual mild aortic stenosis. And whilst this may be acceptable for patients in their 80s or even in their 90s, it is arguably of uncertain acceptability in much younger patient cohorts, and particularly those of 65, 70, and 75, as would currently be supported by the American College and AHA guidelines. A nirvana, therefore, for new developments in the field is to implant patients with healthy, normal aortic valves, which arguably will be more durable over long-term follow-up. So as we begin to conceptualize the concept of an ideal aortic valve replacement, we would want one that was predictable and safe to use, that would offer optimal hemodynamic performance from the get-go, would be associated with a low incidence of complications in short, medium, and long-term follow-up, and ideally would be a single implantation that would last the patient their lifetime. Currently, we're not there, of course. Evidence is still evolving. Operator techniques are continuing to improve, particularly as TAVI expands to new centers. The technology is advancing, but in short, current Tavr platforms were not really designed for today's Tavr patients as we treat intermediate and low risk and younger aged patients. Therefore, as I've said, we need to shift the focus away from the procedure itself to the longer term durability and the expectations of the patient's longer lifespan. We therefore want valves that restore normal or as near to normal as possible hemodynamic function, a valve that is durable, and one that is either an index intervention that lasts forever or is designed with a secondary intervention in mind 1 or 2 decades later. And to achieve that elusive goal, we need robust, larger scale durability data from both randomized trials and national and international registries. We need improved designs and implant techniques that reduce the current rates of complications, including paravalve leak and pacemaker implantation. We want valves that are aligned with the natural connoisseurs to allow ease of coronary access in the future. And we want hemodynamic function, which restores the diseased aortic valve back to the healthy status. And I'm happy to report that there are advanced mechanical and tissue engineering techniques underway which are addressing these problems and which offer a tantalizing future for the further growth of this amazing technology. Thanks for listening.
Well, thank you very much. And, I'm certainly wish Bernard could have been with us, but obviously he's in London at a much different time period. But I think that was a great beginning and an overview of what we could hope to eventually achieve in terms of longevity with transcatheter valves. Following this, we'll have Dr. Michael Reardon speak about what we currently know about the longevity of transcatheter valves. Michael?
Well, thank you. And Vinny, thank you for having me on. So it's great to follow Bernard. Bernard gave us a really a wonderful introduction to this topic, something that I know we've all thought about our entire career. Certainly surgeons have thought about this as we've been asked to choose valve type for patients. And when we think about the lifetime management, there are some things that are really critical, and there are things that are happening that force us to think about this. Of course, there's been several low-risk trials, 2 in the US and 1 in the UK, randomized trials that have come out. New guidelines, Bernard has mentioned that a little bit. The VARC-3 definitions of valve deterioration and failure have come out. And of course, as Bernard mentioned, in the US, Tavr procedure now not only outpacing isolated aortic valve replacement, but all aortic valve procedures that we can think of. And as we have seen this, we're seeing things that are becoming more important, such as younger age. The average age in my institution used to be just over 80. It's now in the high 70s, and I predict by next year it's going to be in the low 70s with the way I see things moving. And the life expectancy is going to go up along with this younger age. And in these younger patients, they tend to be more active, and we need to be able to provide them with increased exercise tolerance and a more durable valve. And the patient really wants a valve that is going to last them for life. Now, there are 2 low-risk trials that came out in the US. There's the Partner 3 trial, which my co-panelist Michael Mack ran with Marty Leon. And there's the Evolute low-risk trial that I had the pleasure to run with my co-PI, Jeff Popma. The Partner 3 trial, of course, used a composite endpoint of all-cause mortality, all stroke or rehospitalization. And quite stunningly, Tavr was markedly superior to surgery at the 1-year endpoint. In the Evolute low-risk trial, Jeff and I used a primary endpoint of all-cause mortality or disabling stroke and used a Bayesian analysis to get a 2-year endpoint out that showed non-inferiority. And in fact, the complete 2-year data is out now for the low-risk trial, and it's still strongly non-inferior. And in fact, if we used a composite endpoint of all-cause mortality, disabling stroke, or rehospitalization, it too was positive. And when Marty Lee and I presented this at ACC in 2019, this really created quite a stir to have 2 such aligned trials being so positive for Tavr. And of course, that led to the guidelines that just came out from Catherine Otto and Rick Nishimura. And as mentioned, risk is no longer contained in our guidelines from the ACC and AHA when you look at your choice between a surgical aortic valve replacement and TAVI. In fact, there's just 3 groups by age. If you're 65 or less, or you're going to live over 20 years, the guidelines still recommend a surgical aortic valve replacement. However, I can tell you in my practice, patients are coming in that are less than 65 on a daily basis looking for a Tavr and looking for guidance. If you're 80 or above, or you have a life expectancy less than 10 years, and you're anatomically appropriate for a transfemoral Tavr, Tavr is recommended. And then there's a big group in between 65 and 80, where you really have to look at the anatomic risk of Tavr versus the physiologic risk of surgery and the patient's desires and weigh those together. But at the lower end of this, pretty much everybody that comes to me wants Tavr. and they tend to be more active, and they need really two things. They need better hemodynamics, and they need the potential for a longer lasting valve. So why do we need better hemodynamics in younger patients? Well, this is actually, it goes back to Gorland's initial work in the 1950s and the dynamics of the circulation in aortic valvular disease. And what Gorland did was he graphed aortic flow on the vertical axis versus mean gradient on the horizontal axis. He looked at different families of fixed EOAs. And then these two red lines represent fixed cardiac work at normal flow, which is about 220 or 230 cc's across the aortic valve, versus high flow, 550. And there's a couple of things you can see. One is you go up in different EOAs by the same amount, the change in gradient is not the same because it's related to the area, which is related to the square of the radius. But most importantly, what you can see is until you get to an EOA of about 2, you really cannot increase your flow without increasing your gradient. So until you start getting close to 2, if you're a young patient and you want to do vigorous exercise, you'll be spending half your exercise with a fairly substantial gradient. Now, we have a lot of knowledge from the surgical world about what patient prosthetic mismatch or valves too small for a patient's needs will do to you. And this is Fallon's work looking at the STS database and looking at people 65 or older that had an isolated surgical aortic valve. And they found almost 60,000 patients. And what they found was that any degree of patient prosthetic mismatch significantly decreased your long-term survival, and it increased your readmission both for heart failure and for reoperation for aortic valve disease or structural valve failure. So we know that if we don't give you good hemodynamics to begin with, you're not only going to decrease your survival, but you're going to do less well as far as valve durability. This comes from Doug Johnson, the Cleveland Clinic, one of Samir Kabadia's surgical colleagues there. And what Doug showed in surgical valves, if you came out with a mean gradient over 20, you had an exponential rise in your valve failure. So 20 is a pretty good inflection point that once you get above 20, the risk of having failure goes way up. So how long do surgical valves last? We know human valves, my valve at 68 still seems to be going strong. We hope they last a lifetime. They don't always, but certainly they're going to last a long time. Surgical valves start to fail between 5 and 7 years and really have an inflection up at about 10 years. Now, this, of course, is dependent on how old you are when I put the valve in. The older you are, the further out that inflection point moves. The younger you are, the sooner that inflection point is. But we do know we start to see failure around 7 years. And so until we get to about 10 years of good data, we really don't know where we stand. So what do we know about surgical valves? Well, one of the problems that we've had with surgical literature is that we as surgeons have often defined valve failure as patients coming back in for reoperation. And of course, reoperation is a pretty gross measure of valve failure because we lose patients to follow up and some patients just won't come back in. But even with that measure, our data is not always this good. You can look across these papers that claim 10-year durability, and what you see is you get to 10 years, the number at risk can be pretty small. If you look at the fourth red bar over, at 10 years, there's one patient at risk. Well, if you have one patient at risk, you really can't claim 10-year durability. You really need 20% of your starting group to have any meaningful number. In fact, the other problem is if you look at the mean follow-up, the mean follow-up is nowhere close to 10 years in any of these. So again, some of our data has been a little weak. I think one thing that Tavr has done is it's forced us as surgeons to actually take a better look and follow our own durability better. So what do we know about Tavr valves? Well, if you look at the Partner 2A trial, what you see at 5 years is that for the new generation S3 and for surgery, they seem to be tracking. And for significant valve failure, it's about 2.7% at 4 years for the S3 and 3.5% for surgery at 5 years. XT was a little higher, but of course we don't use XT anymore. Bernard has mentioned the Notion trial, the Nordic trial run by Lars Sondergaard. They're out to 8 years now. And this is the tracking here is for moderate valve dysfunction, which is defined as a mean gradient over 20 and a rise of over 10. And what you see is for Tavr at 8 years, it's 14.1%, and for surgery, it's 28.5%. Statistically significantly better for Tavr for moderate dysfunction at 8 years. And this is with the first generation core valve, not even our current generation valves. And of course, VARC3 definitions and endpoints are out now for us to use as we look at this. And we look at a number of different types of bioprosthetic valve dysfunction. You can have structural valve deterioration where there's an issue with the valve itself. You could have non-structural valve dysfunction where you can have paravalvular leak, other problems around the valve, but not with the valve. You can have thrombosis and you can have endocarditis. And all of these can come with or without hemodynamic changes. And they go from stage 1, where we see morphologic changes without real hemodynamic changes, to stage 2, where we see moderate hemodynamic changes, like a mean gradient over 20 with a rise over 10, some decrease in your EOA, some decrease in your DVI, some increase in your AR, or stage 3, where you're starting to see large gradients, significant decrease in your EOA, significant drop in your DVI, or significant increases in your AR. And it's when we reach stage 3 that we really have valve failure on top of valve dysfunction. And if we look at structural valve deterioration based on a definition of moderate at 1 year from this paper from the World Congress of Cardiology, we see for Evolut, it was 0. For the SAPIEN 3, it was 16%. And this may well be, since it's defined as a mean gradient over 20, the fact that the supraannular valve has a larger EOA and has a lower mean gradient to start with. So certainly what you want to start with is the largest EOA and the lowest gradient that you can possibly have. Now, as surgeons, we've had to deal with this with patients, and when we choose between a mechanical or a tissue valve, we're having some of the same conversation now with Tavr. If you're 80 years old in the US, you're going to live about 10 years. If you look at the structural valve deterioration for the Carpentier-Edwards pericardial valve, which is shown in this upper right box, for 80-year-olds at 10 years, it's going to be about 4 or 5%. It's pretty good. 75, you're going to last 13 years. It's up to about 7%. If you're 65, which is where we had a cutoff for our guidelines, you're going to last a little over 20 years, and now it's up to 18%. So a fair number of these people are going to get a second procedure. If we went down to 50, you're going to live about 35 years, and if we get up to 35 years, we can't even see it in the box. But a large number of these people will have failed. So if you're 50, you're probably going to get 3 procedures with the valves we have right now. So durability can really be defined as the absence of structural valve deterioration. That can happen in a couple ways. You can have a rupture or a tear, or you can have calcification that is related to the immunologic response and the cytotoxic response. That's really the tissue science. Bernard has already mentioned that there's some really exciting new advances in tissue science that we think is going to decrease this immunologic biochemical response. And then there's biomechanical leaflet stress and coaptation. We've known as surgeons that the more suture holes that you have to put in the valves, the more pieces you put together, the greater the chance of this valve failure and stress at areas where things are put together. So this is the valve design. And if we combine tissue science and valve design, we think we can give you a valve that lasts longer and works better at the same time. So thank you, Vinny. Thank you, Paul. And I will turn it back over to you.
Thank you, Paul. That's the commonest phrase of last year for sure. But Mike, this was a great talk, and you really highlighted many issues, and more importantly is the younger age, of course, can influence the number of procedures, because the patient preference has now shifting towards biological valves. So it gives me a great pleasure to introduce Mike Mack, and this is a great segue to his talk about what's happening in the tissue science, which is basic backbone of reducing the number of interventions in these patients.
Thank you very much, Vinny. Let me get to presentation mode here. Great. So Vinny and Paul, thank you very much for asking me to participate in this webinar. I think this is the critical issue that we have right now in terms of aortic valve replacement, and that is durability. I think that Bernard and my Texas other Michael, my alter ego Michael Reardon, have set the table beautifully for this. And specifically what I want to talk about here is the techniques of tissue science for leaflet preservation and durability. Samir, to follow me, is going to talk more about the mechanical aspects of this. So this is my conflict of interest disclosure. I have been in the leadership of a number of trials in the structural heart space. So we have a wide range and variety of options for bioprosthetic aortic valve replacement, be it surgical, be it sutureless surgical aortic valve replacement, or be it by a transcatheter approach. But there is one thing that we know for sure: all bioprosthetic valves will eventually fail. What we don't know for sure is which one will fail first. Is there a differential failure rate of surgery versus Tavr? And what are the reasons for failure? We do know that there are some surgical valves now, such as the mitral flow valve, that have shown early structural valve deterioration that have to do with a number of factors that are both biochemical and biomechanical. So you've heard this from both Bernard and Michael, but I love this slide. And this kind of says to me better than anything else why durability matters. In Tavr, until the present time, because of the age of patients treated, the valve outlived the patient. We're now moving to the era where the patient is outliving the valve. And that is shown very well in this slide. If you look at the purple rectangle, a patient 87 years old needs a valve to last 5 years. A patient 77-year-old needs a valve to last 10 years. A patient that's 69 years old needs a valve to last 15 years. And by the time you get down into your low 60s, you need a 20-year valve. And as you heard from Michael Reardon, we don't know how long valves last. You know, we've always said that surgical valves last 12 to 15 years on an average, but because of the competing risk of death and because of the low number of and the criteria of reoperation, I don't think we really have a handle on it. So this is the critical question, and we don't have the critical answer at this stage. So why do bioprosthetic valves? And I should mention, from a surgical standpoint, about 92% of all adult surgical valves replaced are bioprosthetic valves, and only about 8% are mechanical valves in current practice. So why do bioprosthetic valves fail? Well, the main cause is calcification. And the calcification occurs most commonly in the commissural and basal areas of the leaflet, which results in stiffening or tears, leading to either valvular stenosis or valvular regurgitation. And that's very dependent upon the valve type and the type of tissue, whether it fails with stenosis or regurgitation. The newer generations of bioprosthetic valves have attempted to prevent or delay this calcification and tissue deterioration by improvements in tissue fixation and anti-mineralization treatment. And indeed, great strides have been made in these two aspects of tissue preservation. Now, as Michael has said, calcification occurs for two reasons. One is biochemical and the other is biomechanical. I'm going to focus on the biochemical aspect of it, and Samir is going to focus on the biomechanical aspect of it. So from a biochemical standpoint, why does calcification occur? It occurs both because of an immunogenic response of the body to the foreign tissue, as well as a cytotoxic response that has to do with a tissue preservation. And this whole field is what's referred to as tissue science. Now, there's multiple options for valve leaflets. The most conventional used is bovine pericardial leaflets. Both porcine valve and porcine pericardium have been used as leaflet material, as well as in the early days of Tavr with the Ptfe valve. There actually was equine pericardium that was used for valve leaflet. There are tissue engineered technologies, and there are significant advances in other material platforms that are being used, either synthetic scaffolds or polymers that recruit autologous stem cells from the patient to populate the scaffold. And there's actually what is referred to as bio-living scaffolds or bioabsorbable scaffolds, in which the scaffold recruits autologous cells, and then the scaffold bioresorbs. There are specific challenges associated with Tavr design, you can't think of a Tavr valve as the same as a surgical valve, just mounted differently, because there are different aspects of the delivery of a Tavr valve that may affect the calcification of the tissue. And that is the damage that occurs with the crimping process associated with delivery. If you have less than full deployment of the stent frame, you will get malcoaptation, and not all leaflets deploying equally and coapting equally. And then if post-dilatation occurs with it, or the dilatation that occurs with the balloon expandable valves, there may be further tissue damage associated with that. So what is the advances that have been made in tissue science that may improve leaflet durability? So first of all, the biologic tissue is not living tissue. And there are the reaction to it from the body is an immunogenic response. So a lot of the focus is removing all of the cellular debris, including the cell-free DNA from the leaflet. Extraction of phospholipids that also can stimulate an immunogenic response. Elimination of aldehyde residuals, which are part of the preservation process, and then storage in a non-aldehyde solution. Also, there's a lot of basic science behind that, why that may improve leaflet durability. So this is a very busy slide, but it's worthwhile looking at. On the left is all of the different bioprosthetic valves, both surgical and Tavr valves, and their method of preservation. What we want to focus on this evening is the ADAPT valve, which is made of bovine pericardium. There's both a surgical and a Tavr prototype for that. The Thermofix is what's used in the most commonly used surgical valve, the Magna Ease valve, which is Thermofix. And you can see the number of other options that are available, both in terms of preservation and anti-calcification treatments. If we move to the center of the slide, the ADAPT technology of anti-calcification starts with harvesting and washing of the valve and extraction of phospholipids. There then is a process that decellularizes the tissue, including all DNA and RNA removal from the tissue. There then is tissue preservation that occurs with a monomeric glutaraldehyde, which is a significant an advance over polymeric glutaraldehyde, which is used for most tissue valves, in that it doesn't leave free aldehydes that are significant in terms of calcification. Then detoxification occurs, leaving no glutaraldehyde residual, and then sterilization in a non-glutaraldehyde process, and then ultimately storage without glutaraldehyde. If you look on the right, the way that most commonly tissue valves are preserved at the present time, they also undergo phospholipid extraction. However, in most all valves, there still is cellular and DNA debris left in the valve, which is an immunogenic stimulus for calcification. Polymeric glutaraldehyde is the commonly used tissue preservation for it. And by that, free aldehydes are only partially removed. Glutaraldehyde is used for sterilization, and then all valves except the Resilia valve are stored in glutaraldehyde. And so this is the ADAPT cell, the ADAPT valve with the acellular calcification treatment that you can see on the right here, that has no residual DNA, no glutaraldehyde, no calcification, and is a single piece of bioprosthetic material that avoids all the suturing that Michael referred to that further traumatizes the tissue and leads to calcification. So this is both the preclinical and briefly the clinical data that shows that this acellular anti-calcification treatment may make a difference. If you look in the rat model, on the left, you can see the DNA content of the different tissue with the ADAPT tissue. On the right side of that, showing that there is no DNA left in the residual tissue. In the center is looking at the polymeric versus monomeric glutaraldehyde preservation, and there is no inflammation present by virtue of a fluorescent stain. And on the right is the calcium content in the rat model out to 8 months that shows that the Anteris ADAPT valve has virtually no calcium content in the tissue. So there's multiple other options that in this field going forward to improve durability of valves. First is synthetic scaffolds that are bioresorbable, as I referred to earlier. And Zeltis is the one that's you may have heard of and is probably farthest along with this technology. There's multiple polymers that have been used, including polyurethane polymers, silastic polymers, Ptfe. Unfortunately, for the whole space, about a month ago, Gore announced that they were exiting this space with their project for Ptfe valves, which is a shame because there were 16 valves that were implanted in children, which were a number of years out with excellent results. So I think that that is a setback to the field. But also exciting is the Foldex valve, which is a siloxane-based polyurethane urea called Life Polymer. And Dave Hymanson at St. Vincent's in Indianapolis just implanted the first of these valves in the mitral position this week. And then there's the exciting area of living bioscaffolds, which do have the ability of ultimately reabsorbing. So in summary, valve durability is the key issue now as we address the lifelong management of patients with valvular heart disease. And we can't just think that you can do a valve and a valve and a valve and a valve and a valve, and that we're going to have 3x valve durability. That's not going to be the case. And we need to get the first valve to last as long as possible. Developments in newer generation bioprosthesis are needed to prevent or delay calcification and tissue deterioration by improvements in tissue fixation and anti-mineralization treatment. And we now have advanced tissue technology, which shows great promise to improve valve longevity. So again, thank you, Paul and Vinny, for asking me to participate in this symposium.
Thank you, Mike. Fantastic presentation as always. Certainly a lot to think about in terms of tissue processing and the impact on durability, and we'll definitely have some questions for you in the discussion. So we'll finish the talks here with Samir, who is going to be talking to us about the impact of tissue choice on hemodynamics. Samir?
Thank you very much again for the invitation to this great webinar. I myself think that they gave Dr. Mack to talk about the biological and more difficult area. And for me, it is a simple thing that what is the valve design and hemodynamics, that how we select the hemodynamics. So with that in mind, the most important thing, and this is a very simple slide to say that when you have mild, moderate, or severe aortic stenosis, what do you really have? What you really have is the aortic valve area is narrowed. And if you look at it, healthy aortic valve area is 2.5 to 4 centimeters square. It comes down to 1.5, 1 to 1.5, and less than 1. This is the ACC/AHA guideline definition. Most of the patients that we see have an aortic valve area of 0.7, 0.8 in that range when they are symptomatic. But it's very important to recognize that the aortic valve area is typically 2.5 to 4 centimeters square. It's also important to recognize that the pressure gradient is less than 5. And if you look at the peak aortic pressure gradient, that is also fairly low. And the DVI, the Doppler velocity index, is normally 0.7. And in a very severe aortic stenosis, it is 1/4 or 0.25. So what do we achieve right now? So of course, this is a busy looking slide, but here, if you focus on this part, the SAPIEN 3 or Evolute, and if you look at the EOA, this is what is published, is 1.6 centimeters square, mean gradient of about 11. The DVI is about 0.43. For the Evolute, the supraannular valve, it is 2 centimeters square, mean gradient is about 7, and the DVI is 0.6. So remember that this supraannular valve design does provide a larger area for the aortic valve. Now, what is a good hemodynamics? So when you say that you want to restore good hemodynamics, what does it mean? Of course, what it means is that you should not have paravalvular leak. Hemodynamically, this is not a good thing because you will have increased LV and diastolic pressure. We'll talk about all other things: single leaf, single piece, valve geometry, 3D shapes of the valve, supraannular placement, and commissional alignment. Some of this may be well known to you, but some of them may be new concepts. So if you look at the paravalvular leak, now what is a paravalvular leak? Is that when the valve is not sealed properly, there is a paravalvular leak. And when we started initially, until the partner 1A data was published for 2 years, we did not think that this mild or moderate paravalvular leak was very significant for the mortality. But now it is very clear that even mild paravalvular leak may have some negative impact, not necessarily on survival, but may also on LV function. Moderate or severe paravalvular leak is definitely not good. And if you look at the PVL 2 to 3, that is moderate or severe paravalvular leak, still in SAPIEN 3 is 2%. It comes to 4.5, 4 to 5% in XT valve, and Evolute is 4%. So there is 4 to 7.4% in the surgical or transcatheter aortic valve replacement, that much of moderate or greater paravalvular leak that you see. How about the geometry of the valve? Of course, surgical valve, which are implanted and sutured in place, and so they are surgical. They are circular. Now, if you do look at the Tavr valves, this is not true. So if you look at the circularity of the Tavr valve, many of the valves are not circular, they're oblong. And what does that do? If you have this valve is designed to be circular, so the leaflet coaptation is very dependent on a circular geometry. If you have non-circular valve, it may be prone to halt, meaning that the leaflet thickening or thrombosis, or ultimately it's important for the durability, because when you have leaflet thickening, ultimately that leads to a fibrosis, calcification, and increase in the valve gradient. Very importantly, it has been shown again and again that if you have a supravalvular design, your EOAs are larger. And this is very important because, again, aortic stenosis, what we're treating is narrowing of the aortic valve. So if you can increase the valve area, that is obviously beneficial. And if you have supraannular valve design, the halt is also less. Whether that translates into better long-term durability or not remains to be seen. But at least it is possible that the calcification-like failure will be less with supraannular design. Maybe the tears of the leaflet can be higher. However, we do not have this data at this time. So if you look at the Dura valve, Dura AVR, it's a very unique design. So this is the leaflet provides a very nice single leaflet. And as you can see here, see the commissures, how they are connected in the other valves. And this is the SAPIEN 3 valve. And this is the Dura valve. And if you see that the collagen is aligned, orientation is similar to the aortic valve. It's a single piece design, and it does not have stitches, or it has very few stitches. So if you can see it here, this is the Dura AVR versus the S3 valve. What is commissional alignment? Commissional alignment means that the valve is now oriented in the way the natural valve was oriented. Why it is so important? First of all, the commissional alignment or misalignment is very common because when we deploy the Tavr valve, the current valves, we do not have a way to turn the valves to align exactly to the commissional anatomy of the person. And so there are several different studies looking at this with CT scans, and the definitions are that if you have commissional alignment 0 to 30 degrees, this is considered an alignment, meaning that if your commissure is within 30 degrees of the natural commissure, then you can be considered aligned. And if you have malalignment, meaning 30 to 60 degrees, obviously after 60 it's again 30. So 30 to 60 degrees is considered as malalignment. And if you look at this, so in the balloon expandable and self-expanding valve, both of them have 40 to 50% severe or moderate commissional malalignment. What it means is that there is a 50-50 chance that you will be aligned or you will not be aligned in the current generation of valves because we don't have a way to align them. So if you look at this is a very important slide to say that the early first-in-human studies of this Dura AVR, if you look at this, if you say that the mean pressure gradient was only 9 millimeters, plus minus 4, The aortic valve area measured was 2.3. Remember the prior studies that I showed you, 1.6, 2.0, and now it's 2.3. So it's even larger than currently available valve. And DVI is similar to what you would see in a normal valve of 0.65. So this is an outstanding hemodynamic performance if you look at the hemodynamics of a single piece aortic valve. So what we have seen, that as Dr. Michael Mack showed, that this valve has an adept anti-calcification process. So as you saw that the DNA is not there, and the valve is biologically less likely to calcify. The 3D design of the valve is such that you have a single piece of aortic valve. So this is a very important part to understand, that this is a single piece valve. So the sutures, as Dr. Mike Reardon was pointing out, is not existent. And the specific system for delivery is such that you can align the commissures. And this is, again, very important for long-term durability and also for access of the coronary arteries. So I'll stop there, and then we can entertain some questions and discussions.
That's fantastic, Samir. And thank you for that presentation. I think there's a lot to talk about here. Perhaps I just want to, I'll kick it off with some initial thoughts, and I would love to hear from you all on these things that were going through my head listening to you. The first thing I want to touch upon is what do we really want to expect from a Tavr valve? And the reason why I go back to this is because I know Michael and Michael both showed slides on life expectancy according to age. And it was basically that around 65, we would expect people to live 20 years or so, and we would need a valve to last that long. Now, I want to, for the sake of discussion, or perhaps not, I'd like to push back on that and just ask, patients with AS often may not live like a normal patient, because that's the average life expectancy, and they often have morbidities, and they may not need to live that long. Is 20 years really the standard that we need to uphold when we're looking at patients in that age group, or is it less? Or how do we get to that 20 years is how I would leave it.
Well, I'll start off the comments, Paul. It's not just the comorbidities of AS. It's that when we as a surgeon put a surgical valve in you, we're just exchanging one disease for a lesser disease. And people have looked at this over and over again. The insurance industry have done a lot of work on this. Is if I replace your aortic valve with a mechanical valve or a tissue valve, you lose years of life compared to a normal population, because you still have some degree of aortic stenosis. And the younger you are, the more years of life you lose. So that if I do an AVR in a 40-year-old versus an AVR in an 80-year-old, the 80-year-old's not going to lose many years of life because they don't have many left. The 40-year-old's going to lose a lot of them. So the life tables I showed you, correct. Those are for normal people. As soon as we replace your valve, unless we could do it with a normal valve, you will lose years of life. And we see things like mitral repair where that doesn't apply because we leave your valve in. Or aortic valve repair, a successful aortic valve repair for AI, you go up to a normal lifespan. For any prosthetic valve, you're right, we lose time.
So that it gets down to, the question of competing risk, right? And Mike Mack, you mentioned this in terms of the structural valve degeneration. Competing risk of death makes it hard to judge durability. And how do we judge it if structural valve degeneration is one of the reasons for early death, as you just said, Michael Reardon? How do we judge that, and what do we expect?
Well, I think that, our colleagues at the FDA were very prescient here in terms of mandating in both of the low-risk trials that patient be followed for 10 years. And I think by 10 years, we'll have a critical mass of patients that we will know what the valve durability is versus the competing risk of death. and we'll have some idea of both absolute and relative valve durability in Tavr versus Savr. So I think that's the first part. The second is, you alluded to, Paul, is does aortic valve replacement by whatever route return patients to their normal life expectancy? And I think at the current time, we are operating on patients where in the late stages of aortic stenosis, when they already have end organ damage, they have significant fibrosis in their ventricle. And there's a lot of work being done to identify and perhaps treat earlier patients that are at risk of having end organ damage. So for example, the early Tavr trial is looking at treating asymptomatic patients. There's a trial being proposed now of treating moderate AS patients. Partho Sengupta has done a lot of great work using artificial intelligence to look at predictors of rapid progression of aortic stenosis. So I think we are going to end up treating patients with aortic stenosis at much earlier stages than we have before, when surgery was the only option. We will identify those at-risk patients. We will be able to treat them before they have end organ damage. And because of that, tissue durability is the key factor that makes early treatment a viable option.
Yeah, certainly we have the moderate AS study, which Edwards has put out there, and we know Medtronic is planning one as well. And it seems that we're just moving that disease spectrum up earlier and earlier because our treatments are safer. And now I guess the question is just whether the treatments will last in terms of durability. Samir, I have a question for you, and that is that Mike Mackin mentioned some things about Tavr versus Savr, and in terms of one being more durable than the other. And there was a question basically, why should a Tavr be the same in terms of durability as a Savr in terms of design? We're crimping these, we're ballooning them, they're not circular when we deploy them. The Notion data says it's Tavr may be better than Savr in the long term. That surprised me a little bit. Does that surprise you?
No, it does surprise me. And I think the question of durability and how you compare Savr and Tavr is a good one, because when you compare, let's say, two treatments, the risks are different. Then the benefits can be that if you have a better treatment for valve failure in the future, then those durability questions will be less important. However, I do agree personally that without a circular valve, without damaging the leaflet, valve being deployed in a commissionally oriented way, it is very possible that the Savr valve will last longer than a Tavr valve. And the definitions used in the Notion trial may be one of the reasons why this happened, that the valve durability looks so much different. But the bottom line is that we need valves that last longer, because if we are going to go to early Tavr, moderate AS, and if we don't have a durable valve, we will hurt people. Yeah. Because I think that the AS, although moderate AS is significant, we have followed patients for years with moderate AS, and people tend to do okay as long as we are going to now replace the valve. And if no AS is better, obviously, but if we are going to give them a disease with a bioprosthetic valve at a younger age, that is going to be, I think so it's very hard to do these trials, in my opinion, because the long-term consequence of doing an early valve replacement cannot be determined unless you follow them for a long time. And the guideline is very impossible to follow, to say that who has 20 years life expectancy. You know, we don't even know who is going to live few years. 20 years is a very, very long time, right? All the people who retire from Cleveland Clinic, for example, the model for Cleveland Clinic for the benefits thinks that they are going to live 78 years. So even though these are healthy doctors retiring, so the financial modeling is at 78 years. So if you are going to say that now you're going to have a 65-year-old guy and that he's going to live 85 years, impossible to determine that, right? So how do you say that how long somebody is going to live? So I agree that the current strategy should be to have the durable valve. That is what I think is the bottom line, that we need a durable valve.
So Samir, the message I got from there is don't retire from the Cleveland Clinic because the 7-year clock starts ticking.
Or retire early. If you retire early, at least you have more retirement.
So I have a question for both the Mikes and Samir as well, that we are really addressing a very important question of durability and younger patients want. Is it also important that we should also discuss and report anticoagulation in sequencing what will be needed? Because most patients want, say, a valve in valve or a Tavr in Tavr, etc., but we don't know at present how many of them are going to need anticoagulation. It begs the question, and the concept which Mike recently put is we need the first valve to last longer without anticoagulation as well, because that's the premise of bioprosthetic valve.
So Michael, you want to go first?
I'll go first quick. I agree with you. You're absolutely right. People don't want to take anticoagulation. It needs to last a long time, and it needs to have an EOA that's over 2 and a DVI that's north of 0.6, so these people can get out and do normal things. Anything less than that is going to get us in trouble. And any anticoagulation we put patients on, they're going to be leery of. And the older you get, the harder it is to remember to take your medicine anyway. So you don't want to be on your 3rd valve and need a bunch of anticoagulation.
So, what I would say, Vinny, is what we know from the low-risk trials and the surveillance CT scans for HALT that were done is that valve thrombosis or HALT is common. It occurs in about 25 to 30% of both surgical valves and Tavr valves within the first year. It is more common early in Tavr than in SAVR, but by 1 year, there's a catch-up phenomenon. Most of the time, it is not associated with clinical events. There are some patients that get it early that resolve. There are some patients that don't have it early that get it. I don't think we have a good handle on which are those patients that are going to get it and which are those patients that it doesn't resolve in. I do think it is the pathogenesis of early structural valve deterioration. We always have said to patients prior to surgery, this valve's going to last 12 to 15 years, and the patient comes back at 3 years with early structural valve deterioration, and we had no explanation for it. I think valve thrombosis is the explanation for early structural valve deterioration, but anticoagulating everybody is not appropriate. We need to further define those patients who are at high risk for valve thrombosis that doesn't resolve, and those are the patients that need anticoagulation to prevent valve thrombosis and early structural valve deterioration.
Thank you.
Mike, do you think that we should be doing CT on all of our patients as part of routine practice for surveillance?
No, my answer 3 or 4 years ago would have been yes. I do think, again, that the FDA was correct in terms of mandating surveillance CTs without anticoagulation, and that we're a lot smarter about it right now. I think that routine CT is not appropriate. I think for-cause CT is appropriate when you do have a change in gradient or when you do have clinical symptoms, especially in patients, for instance, valve and valve that we know are higher risk for valve thrombosis. I don't think that any patient should undergo a re-intervention without having a CT first to determine whether valve thrombosis is present and whether it is treatable with anticoagulation or even thrombolysis.
I'd second that, Paul. When we got the Evolute 4D CT data, I looked at it with Jeff, and it was all over the map. I was saying, what are we going to say about this, Jeff? Because it was really hard to parse. And if we start CTing everybody, we're going to start treating things that we have no idea if it makes any difference, and we will cause harm with anticoagulation. It is not a benign event, as we've seen in some of our trials.
Well, with that, I think we're at the top of the hour. Vinny, did you have another comment?
No, I had a very interesting thought I wanted to ask Samir and both the mics very quickly is, what should be our expectation from the industry for data when we talk to patients? What should be defined? Should we not define what is early data, midterm data, and long-term data based on the claim made by the industry? Say, someone says it's going to last 15 years, we call first 5-year data as early data, the 5 to 10 as midterm data, and 10 to 15 as long-term. Because patients do ask these questions, and it's becoming increasingly difficult to answer those.
No, I think at least 10 years can be considered long-term. The question is that how complete are the data? So it is not so important that we have data, but the quality of data is the problem, because if you look at all the literature, it is all over the place because how people define this. That's why WARC 3 is very helpful, that at least there is a structure now. But more importantly, I think the completeness of the data is necessary because this is what is hurting us.
I'll tell you, the Tavr trials have given us a gold mine of data, and the low-risk trials are going to continue that. We'll get pretty complete follow-up for 10 years, something we've never had before.
Exactly.
Well, I love the idea of 10-year data, but in 10 years, I'm going to be a different person, and I'm just thinking, what signals or what kind of things can we use ahead of 10 years? I mean, 10 years is a long time to wait.
I know in 10 years, I'm going to be 78. If I come up to Cleveland, I'm going to be dead. So that's a problem.
Indeed.
Mike Mack, I mean, you're with the FDA a lot. I mean, what are there different ways of looking at it rather than just waiting for 10 years?
So, I agree with the previous comments. I think 10 years is a good benchmark. I do think that the number of patients at risk at that time point is the critical issue in terms of being able to say whether you have a 10-year valve at that point. I think there are some techniques that Philippe Pibereau has pioneered of looking at microcalcification of tissue to determine more than just waiting for a 10-year clock to run in terms of predicting those patients that are having early structural valve deterioration. So that is a CT, a surveillance phenomenon that still is research right now. I think looking at FDG PET CT scanning to determine the activity of calcification is also an important surveillance tool that we're going to see being used more and more frequently. I do think that the FDA also right now is looking at different ways of bench testing valves to determine fatigue fatigue testing for accelerated wear testing. And what has always been used for bioprosthetic valves may not be applicable going forward to other types of scaffolds. So the FDA is actually putting together a webinar to look at fatigue testing for valves to try to be more predictive of which valves are going to fatigue earlier, and whether it's one testing method that applies to all types of valves.
I mean, that's fantastic, because, you know, we've seen early valve failures with some valves that are surprised us. And we know that those valves went through the routine cycle testing before approval, and yet they made it to market. So it would be great to hear more about that.
So I know we're after time, but let me just ask Samir and Paul a question. So let's just say, for example, that we knew absolutely for sure that a Tavr valve lasted on an average 10 years, and a surgical valve lasted an average of 15 years. Would it make a difference? And I bring up the analogy of a lima to the LAD versus a stent to the LAD. The best thing you can do for long-term survival is a lima to the LAD, yet our default therapy is a stent. So if we show that there's more relative longer durability with a surgical valve, 15 years versus 10, does it matter?
I think 15 versus 10 may not, but 7 versus 12 may, for example, because when the aortic valve is lasting shorter and shorter, where years that you see in front of you are measurable, then it makes a difference. You know, when at 10 and 15, it becomes harder and harder. But if it is 7 and 10, and people say that before my kids go to college or before I have a grandkid, I'll need another surgery. So this is where I think it becomes real. So it does matter, because a lot of people come and say that, that listen, I want to not have another surgery until my kids graduate from college. But now younger people come. So they say that, I want to get my kids through college, this thing, that thing. So people will put milestones of life when you give them durability. So it does matter at younger age people that how long the valve will last.
I think it definitely matters, Mike. And the reason why I say that is it's not so much about the fact that it wears out at 15 versus 10, but it's what happens as it's wearing out. Because if a valve is wearing out by 10 years, that means there are changes that are happening to my heart during that time. And if I didn't have to have fibrosis or consequences of whatever morbidities or heart failure that come with that degeneration, that would be better. So it's not just a matter of the valve wearing out, but what it's doing to my heart in the meantime. And, for me, how active I am. I mean, I would want something that would last that longer. And so to me, it would matter. So I'm getting my lima when I need it.
No, come on.
No, I think this is so important. And I think the sequencing part also becomes critical here. Slowly we are going to see, Tavr in Tavr and versus Tavr explant and valve in valve, how they fit into this equation as well of, can you extend that so-called durability from 10 to 15 or 20 years? So there's a long way to go.
And the same argument as lima and stent comes up with a lot of patients. They say that, hey, if you put a stent, you don't burn the bridge of lima. You can always have lima. Same way, a lot of people come and tell me that, listen, if you put Tavr now, I'll be healthy again to do a Tavr. Don't worry about it. Just do it right now. And we do it. This is what is not uncommon also, just at least in clinical practice when they're younger people. They say, at least let us get it now. We worry about 10 years later, you will come up with some new things. And,
I love that sentence.
This is another common thing.
This is the everyday question, right?
Everyday question.
Every day, right? Yeah.
My last clinic patient was 62, healthy, trileaflet valve, I want a Tavr. 62 years old.
Exactly.
We see this every single week.
Sequencing is hard. It's really a hard discussion. If we didn't have to think about sequencing, our lives would be a lot easier. So. Well, anyway, we are past the hour. This has been fantastic. I want to thank Antares for sponsoring this symposium. It's great to see all you guys and look forward to seeing you really, really soon. Thanks again, everyone.